Hello and welcome to my presentation for Facilitating Change, Bridging Gaps in Care for our nursing Capstone integration. Identification of the population at risk. I've been working with COPD patients for many years, and recently, after starting to work in Camden, I began to notice a disparity in available care for them. So the at-risk population are adults with chronic pulmonary disease, COPD, asthma, recently discharged from the acute care hospital. Description of the problem. High numbers of COPD patients in Camden, New Jersey in need of discharge follow-up appointments and the socioeconomic barriers to transportation. There are a few specialists located in the city, and there is an inability of the patients to get to the pulmonary offices that are outside of the city. Description of the problem, observations, and evidence. There are identified relationships to high 30-day readmission rates that are linked to the lack of or delay in post-discharge follow-up care. The number of COPD patients in the New Jersey area has overwhelmed the resources, making it extremely difficult to get follow-up care within a 30-day period. Socioeconomic issues compound this disparity. The availability of local care, there just aren't pulmonologists in the city, and the patients, many of them do not own cars, and as a result either have to depend on family or use public transportation. There's a need for a local, in the city, post-discharge follow-up clinic and urgent care center for chronic pulmonary disease patients to address the gap and improve quality of care and outcomes. The vision for this project is that discharged patients with COPD would have the ability to follow up within 7 to 13 days after discharge from the hospital. This would lead to decreased use of the emergency department and fewer 30-day readmissions. COPD patients will become more capable self-managers with their chronic disease and have improved quality of life. Quantitatively, a 30-day readmission rates for COPD patients will decrease by 5% in 6 months from the program implementation. Qualitatively, the target population will be able to state through teachback better understanding of signs and symptoms, when to seek care, of their medications, and as to their disease process in general. The mission is to create a collaborative interprofessional team that will identify potential services for application to the at-risk population. The team will adapt the services to fit the needs of the COPD population in the city to reduce the gap in care. We hope to provide accessible, specialized care for COPD patients in Camden for both discharge follow-up and urgent care needs. And we need to close the socioeconomic gap in medical care that limits this population from attaining a healthier life. A summary of the plan is to utilize the evidence found in literature searches and apply it to an evidence-based practice model to create an evidence-based practice for follow-up appointments and identify key stakeholders and engage them in an interprofessional team. Using input from the team, identify possible solutions, identify barriers that could prevent us from moving forward, and the goal is to minimize the gap in care. Late in week 3 into week 4, it was apparent that a dual plan was needed, so we developed a quick action plan that would be instituted immediately. The quick action plan is for timely appointments and ride assistance. Biblical perspective on principles that support the mission. The biblical ideal would have us do as Jesus would do. I have set for you an example that you should do as I have done for you. John 13:15. Christ didn't wait for those in need to come to him. He went to where the people were. As these verses illustrate, we are to seek out people in need, not wait for them to come to us. The interprofessional collaborative, the communication took place in various ways: email, phone, face-to-face, and then future plans for teleconferencing and WebExes. Team meetings with individual groups took place in week 1 and early week 2, just to gauge and collect information on some things that were already in place with the CHF team and discharge planning. There was e-contact with the Camden Coalition, which is a large coalition of providers that provides care for complex disease processes. They are actually known nationwide. They just had a big conference in Chicago in early December, and are a very up-and-coming principle and way of dealing with patients with complex medical problems. So we hope to be able to link up with them eventually. Qualitative and quantitative data from the literature search was used to create evidence-based recommendations for follow-up for the COPD patients. In our team meetings, the meetings scheduled with key stakeholders as identified, initial team meetings by conference call, and then face-to-face with phone-in options for those who could not make it. Future face-to-face meetings and collaboration and presentations of information that were assigned. There was a PowerPoint presentation presented to the group, also sent to those who were not in attendance. Discussion and insights regarding the evidence and the gap in care and the at-risk population was discussed, and barriers were identified. While the team agrees that the COPD readmissions are a problem, the plan is probably not a financial possibility at this time. This is a list of the key stakeholders. The core team is listed in red. That would be myself, Donna Antonucci, who is the president and CNO of Population Health and the Clinically Integrated Network for the hospital. Alan Pope is vice president of Population Health. He is a pulmonologist for a large pulmonary group in the area. Pat Cosnett is a respiratory therapist and the director of respiratory therapy at our hospital, Lourdes Health System. Jimmy Hyun is a social worker who is on board to assist us with any of the social issues that we may need. And Danielle Johnson, our administrative secretary. The other members are ad hoc members and will be pulled in as needed for their areas of expertise. Identified barriers, primarily financial, some physical space issues, lack of available time for the stakeholders to meet as a team, and some negativity with just in general with dealing with COPD patients, as they are just a problematic group to deal with. And there have been some previous attempts to create a follow-up schedule for them that has failed. There are potential ethical legal roadblocks due to business agreements, as this team is kind of spread out across different institutions, Camden Coalition, our hospital, and now with our member that is buying us. The implementation of strategies to avoid the roadblocks was basically was the quick right turn to develop the alternate short-acting quick action plan to address the timely appointments and ability to get to the appointments. So that has already been implemented. We're still working on logistics as far as the offices and a call center and things like that, just to make it more of a one-call system, so you're not calling an office and they don't know what you're talking about. But otherwise, the two patients so far that we have scheduled have both had good experiences. Objectives and measurable targets. The quantitative data that we currently have is a 33% readmission rate in COPD patients. So any reduction from this number will be considered a plus in the next quarter. We expect a 5% in 6 months from the implementation of the rapid improvement. Qualitatively, the patients will state improved ability to follow up, improved ability to self-manage. My evaluation of the experience, the rapid improvement process was developed and implemented. It had positive impact, so there was a clinical significance. Process and progress, the project will be ongoing, but we did manage to put something into place within the 5-week period that we have for this portion of the project. Achievements and objectives. Previously stated, 2 patients have already utilized the rapid improvement plan, and we continue to move forward with seeking the full vision. To conclude, I just found forming a team to be the most difficult part. Getting everyone together, everyone has such busy schedules. Insights, the identification of the at-risk population, just thinking of them more as victims of their economy, more so than that they have caused their problem. That was a brain change for me as far as like thinking of COPD patients and compliance. Wanting to make a change is easy. Actual change is hard. It's such a cultural change. It just takes continuous quality improvement and continuous restatement of the goals. Implications for the change project. I'm very happy that it has already impacted a couple of people, and I hope that it continues. And I hope in the future, as we complete our merger, that we will have the resources to make this an actual clinic. Thank you. Thanks for listening. And I'm going to miss all of you, and good luck in the future.